All right, let's get started.
All right, I thought someone was an idiot, but I don't know where that came from because I don't think anybody's an idiot in here. I think you're very motivated, and I'm proud of these. But I feel like an idiot because I've been turning around reading these, and I just realized they're right here in front of me, so I could be the one. All right, so now I'm going to be twisting this way instead of twisting that way. So airway's always priority. Give them oxygen. They need to be ventilated. You're prepared to do that now. And if you don't have a pulse ox and you think that their injury or illness suggests oxygen, give them oxygen. You really can't go wrong giving them oxygen. You know, the biggest mistakes I've had are where people with real disease get brought in with a brown bag that they've been misdiagnosed as hyperventilating when their oxygen saturation is 80. You know, you've got an O2 sat, you should never make that mistake. There's no reason to make that mistake. You know, you can't hyperventilate yourself into hypoxia. If you're hypoxic, there's something going on. You know, if you all hyperventilate now, your sats are going to be approaching 100. They're not going to be approaching 80. So there's something wrong. If their sats down, there's something wrong, and you need to address that. And we talked about, oh, I see, it's got to be pointed to that. All right, so target sat, PO2 of 96 is good. Avoid hyperoxia, but I'd rather have short-term hyperoxia than hypoxia. You know, hyperoxia causes damage by free radicals and stuff like that, and in newborns it causes eye problems and lung problems, but in adults, short-term hyperoxia is not a big problem. As I say, the biggest short-term problem is the problems with the oxyhemoglobin dissociation curve that we talked about.
Do you have an opinion on oxygen during a stroke? Some folks have said that the vasoconstrictive properties of oxygen, or by giving them excessive amount of oxygen delivered to them, causes the stroke to become worse if it's a non-hemorrhagic stroke.
I would maintain an oxygen level between 90 and 96% if I could. I would try not to get to 100, but I think think about what a non-hemorrhagic stroke is. There's a blockage in the circulation. So you've got an area of the brain that is getting no blood flow or diminished blood flow. So the best, if it's me that you're treating, I would like what little blood is getting to that area to be maximally saturated. That makes more sense to me than worrying about vasospasm. All right, toxic free radicals. So treat the hypoxia. Oops. I'll get this figured out by next time. All right. Now we're going to talk about the individual disease processes. Upper airway obstruction, most common is the tongue. Can be dentures, food. If someone arrests while they're eating, suspect an aspirated foreign body. You can have trauma, upper airway burns, allergic reaction, swelling. The signs, basically the inability to talk or breathe. Right, we talked about that. If a burn, then you suspect laryngeal edema, and time is of the essence in that because it's just going to get worse. And the longer you wait to provide a definitive airway, the bigger the chance is you're not going to be able to provide the definitive airway.
What are your thoughts on nebulizing epi in that case? I'll give you an example. It was about 2 years ago, maybe a year ago, there was a huge house fire up in Station 6's area up near Big Canoe in Dawson County. So we had a prolonged time to get there. Nobody gets there quickly. And I had 2 patients, and both of which had soot in their airways. They both dove out of a window of the second story of the house. We had multiple things we were working on, and I call her Honey Boo Boo. She was quite large, covered in blood, and every orifice of her airway was just pitch black. But she had very hoarse voice, very hoarse sounding voice, and so we don't have protocols in our book for nebulized epi. Of course, we don't carry racemic epi. So I went ahead and initiated nebulized epi, nebulized epi, and I called for orders for it as well. And the orders were denied, and they said we need you to give albuterol instead. And that didn't really make much sense to me, because I know that the albuterol is going to work on the smooth muscle down in the lower airways versus epi. We want the vasoconstriction to pull the secretions back in. So what is your advice on that? Let's say if you do have a burn patient, to prevent the need to take that airway, administering a nebulized amount of, or a nebulized epinephrine, and what amount would you recommend?
Yeah, I would think it would be unlikely that nebulized epi would prevent the patient from having to be intubated. You know, there's a burn, it's gonna swell, and you're gonna need to take control. It might make it easier for you to get the intubation.
So it slows it down a little bit, maybe? Or?
Maybe,
okay.
You know, and I guess you could give sub-Q epi if you had to, if you couldn't get orders for nebulized epi. You know, the only caveat is epi in the face of hypoxia is pretty arrhythmogenic. You know, so you want to make sure they're oxygenated before you give a beta adrenergic drug. But I would think either way would be reasonable. Okay, if the burn is present, we talked about that. Watch for urticaria. There are several drugs that cause angioneurotic edema. Most common ACE inhibitors, so I've seen a lot of those, you know, like anything that ends in PRIL, you know, Acupril, Benzapril, any of those are ACE inhibitors, and they affect the enzyme that can cause angioedema. So people will end up with big swollen lips, swollen airways. Sometimes you can turn them around with epi, Benadryl, and steroids. There are newer high-priced medicines that they now have in the emergency room that you can use, but I've seen cases of this where they need to be intubated or even trached, because the angioedema can be so rapid and significant that it precludes any intubation.
Did Sam tell you about his bare nerve infusion?
Yeah, he did.
Okay. Yeah, that was hilarious, by the way. It was really funny. He's sitting there telling us the entire time, "Oh, I'm fine, and his lips are swelling, his tongue's swelling. He's like, "I'm fine, guys, let's just keep going." It was during an advisory meeting. And Geraldo was saying, "Well, just give him Benadryl. And Brandon Sullins was quick enough to say, "I really don't think this is saying, what kind of medicine do you take?" And he said, "Lathenthryl."
Anything that ends in PRIL.
Real sleepy. You need Verner.
Right.
So we transported him.
I don't know how many thousands of dollars that drug is. I mean, they've got a corner on the market. It's really expensive.
Sam said he paid about, or insurance paid about $30,000 just for that infusion.
Wow.
That is crazy.
The drug companies have us all by the short hairs here, you know. Especially they come up with a new drug and they own the market. So, but it is life-saving. And you know, if I had a choice of paying $30,000 or spending a couple days in the ICU with a trach, I think I'd probably come up with the $30,000. So they got us right where they want us. All right, retractions, accessory muscles, we've talked about that. First, you try your basic maneuvers: jaw thrust, chin lift, head extension, nasopharyngeal or oropharyngeal airways. See, I've already forgotten what it's called. This guy in the corner just showed me a whistle that goes on the end of an endotracheal tube. BAM?
BAM.
B-A-A-M. Have y'all heard of those? It's a whistle that attaches to the end of your endotracheal tube when you're about to do a nasotracheal intubation. And the the closer you get to the airway, the louder it whistles. So, I mean, I always put my ear up against it and listen for the breathing, but a whistle is a really neat idea. It goes on the end of the tube. I guess it's disposable, right?
Yeah.
Yeah. It's a great idea. All right. If you suspect a complete airway obstruction and the patient is awake or moving any air, you do the abdominal thrusts. If they're unconscious, you take a look with your scope and hope that you can see it and pull it out. And McGill forceps are very handy. You all know what McGill forceps are, don't you?
Sir.
Sir, in that case, you had just a spool. Say it just went a little too far. We couldn't get it. You know, there's an instruction. Us emergency, so what do we do?
Give them oxygen and bring them. You know, I had a case. This reminds me of a case where a friend of mine who's a medic called me and said, "We've got this lady who's delivering a baby, and we see one arm and one leg. What do we do?" And I said, "Man, you better just put it in the wind because it is not happening where you live." And they did, and we ended up getting a good baby. I incidentally, you know, when I was telling you my history, I left one thing out. So I wanted to be a generalist even before emergency medicine was recognized as a specialty. But my senior year of medical school, the OBGYN department failed to fill its residencies. So a friend of mine and I were offered the opportunity to split a residency spot during our senior year of medical school if we would give them 6 months of our residency in OBGYN. And we did. So we delivered a boatload of babies and forceps and C-sections and everything. As a student, I mean, as a senior medical student, I was essentially an intern in OBGYN for 6 months of the year. And then in my rotating internship, they talked me into giving them 6 months of my rotating internship. So I did medicine and neonatology and did 4 months of OBGYN. So I had a good bit of experience with OBGYN. So I was able to deliver this baby, this one arm, one leg monster thing. And I had to, you know, push it back up and turn it and then deliver it. And we ended up with like a 3/7 Apgar, and the baby went to the unit. And so the end of the story is about 6 years later, my wife and I are eating in this barbecue place, and the waitress comes up to me and says, "You don't remember me, but you delivered my baby. He just got the valedictorian of his first grade class." All's well that ends well. But at any rate, it's not happening where you live. And you need to recognize that there are certain things, you just got to bring them home, because you cannot affect, you know, and I couldn't have affected an outcome. If I couldn't have seen the end of that spool, we're talking about the OR and bronchoscopy and removing it operatively.
You know, along those lines, if you've got a complete obstruction and no way to remove it, what would we, at that point, what we do would just be push it further in so you maybe get one side open, or?
No, if you have a complete obstruction that you can't relieve, then it's probably time for either a needle cricothyrotomy or a cricothyroid tube. You know, because you've got to get air below the obstruction, and that would be the one indication, you know, upper airway obstruction that you can ventilate underneath if you can get an airway in. Now, you know, my senior project in the emergency medicine residency was examining needle cricothyrotomies. Did you know they make an 8 French angiocath? That is a big son of a gun. I mean, you can, you know, it's got a stylet in it, and you can pull that out and almost breathe through it. And we had an oxygen-powered breathing device. you would take the IV and do an IV stick on the cricothyroid membrane, thread it in, put the adapter from a 3.5 French endotracheal tube into the end of the IV site, and then you could hook a bag valve mask or the oxygen-powered breathing device in there. And they did studies that showed that even if you flow oxygen into them and don't ventilate them, you can improve their hypoxia. But you can ventilate them through an 8 French catheter. Or you could put in a small endotracheal tube by doing a surgical cricothyrotomy. But, and there's a chance that you could blow the foreign body out. If you could get air in underneath the obstruction using an oxygen-powered breathing device or a bag valve mask, you might be able to dislodge the obstruction. Was where Brandon had a look there, I thought I was over the line or something. All right, if obstruction persists, ventilation cannot be provided, visualize the airway, grasp the obstruction, supplemental oxygen, bag valve mask. Once again, if you can't clear the upper airway, then a cric would be indicated. They get trained how to do a cric, right?
Yes.
Okay. As I said, I've only had to do a couple in my day, but they're dramatic when they happen. Dramatic. Did I skip a slide or something? I can go backwards. Not sure how we got to here, but IVs on everybody, that's great. I would mostly give my epi IV given the choice. Now you got to give 1 to 10,000 if you're giving IV. You don't want to give 1 to 1,000 IV. 1 to 1,000 is good for sub-Q or IM. Benadryl should be needed for swelling. All right, ARDS. The problem with ARDS is it's not a primary disease. It's secondary to something else, like sepsis or toxic exposures, inhalation damage, something else has gone on that causes fluid accumulation and gas exchange in the lungs. And the primary deficit is a damage to the endothelium of the lung that causes fluid leakage, and the fluid causes a problem with diffusion. Mortality is high, death is from multi-organ failure, and it's the underlying condition that is the problem. We talked about this, so the thickness of the respiratory membrane increases, so oxygen can't diffuse across there, and the patient gets progressively hypoxic and more oxygen dependent. The clinical symptoms are related to the underlying cause. Dyspnea, confusion, agitation, tachycardia, tachypnea, rouse from the fluid in both lungs, low SAT, and you have to treat the underlying condition. Yes?
Pre-hospital, as far as us, would there be any clinical significance between CHF exacerbation and ARDS?
You're not usually going to pick up ARDS in the field. That's usually a later consequence of the underlying disease. So people that become septic don't usually present with ARDS. That's usually day 2 or 3 of the clinical picture. But that's a good question. But the treatment would be similar, Positive pressure ventilation. She still looks pink. I'm looking. She still looks pink. Okay. Try
Our eyes are open, we're okay.
I don't know. People die with their eyes.
Yeah, there's a cardiac arrest call. He's conscious, right?
If they are dead, I would have liked to have not administered the anesthetic before it happened. All right, gram-negative sepsis is most common. There's an endotoxin in the cell wall of the bacteria that damages capillary endothelium. If it's high altitude pulmonary edema, descent is critical. They still treat them with Lasix and things like that, maybe even steroids, but if it's high altitude pulmonary edema, then you need to get them to descend. Access, don't give them excessive fluids. You know, if people have shock lung or ARDS, they're pretty much restricted to necessary fluids. If you overhydrate someone, then it just pushes more of the fluid that they can't keep in their vascular space into the lungs, and then it's a near drowning, and you don't need that. Cardiac monitoring, secretion, positive pressure ventilation is very helpful, and CPAP can avoid the need for an endotracheal tube, which is frequently necessary. All right. Maintain cardiac monitoring and pulse ox and transport them to a facility where they can do Swan-Ganz monitoring. You know, all know what Swan-Ganz is? Swan-Ganz is pulmonary wedge pressure. So they put in a central line and they float a catheter through the right side of the heart, so through the right atrium, through the right ventricle, into the pulmonary artery, and there's a small balloon on the end of the catheter that they can wedge. They blow it up and it causes an obstruction there. And they can measure left atrial pressure from that. So they can tell whether the patient needs more fluids, if there's enough filling pressure, or if the pressure is high, that means that the back pressure is too high and they need to fluid restrict, or diurese, or what. And that is the most accurate way of determining the fluid status of a patient, because you're measuring the left atrial filling pressure using a Swan-Ganz catheter. It's also called a pulmonary capillary wedge pressure.
You guys will see that in ICU and CCU on your clinical.
It is. It's been around for years and years. I mean, we used to put them in back when I was in medical school, and they are the most accurate way of measuring left ventricular filling pressure.
And like Maria just said, you'll also see them being implanted in the cath lab during the cath lab rotations as well.
Okay, on to COPD. So COPD comes in two flavors. There's the blue bloater flavor, and there's the pink puffer flavor. Blue bloaters are chronic bronchitis, which are exactly what they sound like. They have bronchitis all the time, which is an irritation of the airways, the bronchi. They become thickened. There are increased goblet cells that secrete mucus. And so there's mucus plugging and bronchoconstriction causing the disease. And cigarettes smoking is by far the most common cause of it, although other toxic exposures, coal miner's disease, asbestos exposure, and things like that can cause chronic bronchitis or emphysema. Asthma is a reversible obstructive disease, which is characterized by hyperreactivity of the airways to allergens or substances or foods or whatever. Basically what happens is the airway is hyperreactive, it constricts, stays constricted, and that causes the disease. Now, one thing that it took me a long time to figure out, I was a childhood asthmatic, and when one is in the middle of an attack, one feels like one cannot get enough air. And the same is true with emphysematous patients or chronic bronchitis. But the real deficit is not the inability to inhale. It's the inability to exhale. So what happens is you can't get enough air out, So your next breath in is unsatisfying because there's not enough room to get it in. Knowing this, I have successfully talked down a lot of asthmatics by forcing them to exhale longer than they would normally exhale. So if you can get someone to inhale when you raise your hand and exhale when you drop your hand, and get them to squeeze all that air out, they might find that the next breath in is more satisfying than it might otherwise have been. Just a little trick on the side. There's a genetic predisposition for asthma, and we talked about the cause. Obstruction in the bronchioles, bronchospasm, mucus production, and inflammation of the passages, and mucus plugging is a hallmark of asthma. All right. Now, emphysema and chronic bronchitis are really distinctly different diseases, even though they're both COPDs. In emphysema, there is a problem with diffusion, because think of the alveoli like a cluster of grapes with the capillaries running in between each grape. In emphysema, due to the chronic coughing and increased pressure and the toxins, the walls between the individual alveoli break down. And so you end up with these, visualize it like ping pong ball size alveoli, where say 4 or 5 grapes or 10 grapes the walls have broken down and they become one big grape. Well, the problem with that is there's no longer capillaries running in between each of these grapes. There's just a capillary on the outside of each of these ping pong ball size things. Those are called bulli. And so there's decreased area for oxygen exchange. So it's a problem with diffusion, that the air can get into these ping pong ball things, but there's not enough surface area for the capillary to interface with the air containing spaces. So decreased alveolar membrane surface area means less oxygenation. If you do a VQ scan, which is a ventilation perfusion scan on these people, you see that there are defects in the ventilation perfusion, that there are areas that are perfused that are not oxygenated, and vice versa. So unfortunately, what happens is that as the amount of capillary space in the lung decreases, the resistance to blood flow increases. So there's more of a load on the right side of the heart, leading to right ventricular hypertrophy, leading to heart failure, leading to distension of the liver and peripheral edema. You all know the difference between right heart and left heart failure. Okay, so right heart failure, failure of the right heart due to pulmonary hypertension, things get worse and worse, and it'll kill you. Okay, and it kills you from hypoxia. Cor pulmonale is right-sided failure secondary to pulmonary disease. So cor is heart, pulmonale is lung. All right. Talked about weakening the walls. The lungs lose the capacity to recoil, causes air trapping, and the pursed lips is self-induced PEEP to try and keep the alveoli from collapsing, because there's loss of surfactant. Surfactant is what keeps the airway from collapsing. All right. Emphysema is irreversible. You can keep it from getting worse. I mean, if you can convince this lifelong smoker to stop smoking, they will not get better, because you can't regrow your lungs, but they will stop getting worse and stabilize where they are. Not that many people stop smoking, but They are susceptible to respiratory infections and cardiac arrhythmias because they're hypoxic. They may be dependent on bronchodilators. Many of them take steroids and bronchodilators mixed together, and supplemental oxygen. And they are the pink puffers. Have barrel chests due to increased AP diameter and hypertrophy of the accessory muscles. They can have really developed sternomastoid muscles from tripoding and using the excessive muscles to breathe all the time. Weight loss, dyspnea on exertion. Cough is not a predominant factor, although they can have cough. And they do have increased incidence of bronchitis also. They are pink, they're polycythemic. Why are they polycythemic? What is polycythemia?
Increase in red blood cells.
Why do they have increased red blood cells? They're trying to compensate for hypoxia. You know, that's what happened to people that live in Denver too. You know, if you live a mile high, your hemoglobin is going to be higher than if you live in Georgia, because your body compensates for hypoxia by making more red cells.
So would their hemoglobin and their hematocrit be high?
Yes, their hemoglobin and hematocrit will be high. In fact, there's a saying about athletes: train high, play low. You know, so if you train high, you essentially blood dope yourself. You play low when you have this extra hemoglobin. It's, you know, the life blood cell of a red cell is about 120 days. So, you know, it's legal to train in Denver, to train high where you increase your hemoglobin. The hemoglobin is not going to go away as soon as you descend. It's going to be there for months. All right, signs of right heart failure, neck vein distension, peripheral edema, hepatic congestion. I can give you a great trick for telling liver size. You know, you've probably been trained to percuss a liver. The next time you have the opportunity, do what I call the scratch test. So you put your stethoscope over the liver and just lightly scratch where the liver should be. You will instantly know where the liver edge is. The sound is completely different. It sounds like scratching the table here, and it falls off to nothing when there's no solid liver. And that's because the liver is a solid organ, and it transmits the sound great. But if you scratch over bowel gas, there's almost no sound at all. So try that next time. It's a great trick.
Elaborate on that a little bit? You said scratch, like just put the stethoscope and then scratch on it.
Yeah, and not with your fingernail. I mean, you just touch with your finger.
Okay.
You barely even have to touch them. It's painless, and I mean, I have gouged for liver edges a million times until I learned that trick. And once I learned that trick, you know where it is. It's like having your own Doppler. Anyway, that's what you get from me. See, you get this extra stuff.
Does that also work on other solid organs?
Yeah, if there's a solid to gaseous interface, can't think of where that would be really useful. You know, I guess that would work on a pleural effusion too. You know, if you were trying to figure that out, it would travel better through solid water than through lungs. You could scratch it out and figure out where it was. Where else would you use that? I don't know. You can't really get to the spleen to figure out where that is. Livers,
Where exactly do you put the stethoscope?
over the liver, like right underneath the costal margin, where you know liver is.
Yeah.
So right underneath the costal, right underneath the lowest rib, and then just scratch right next to the stethoscope. You should try it. I mean, it's amazing, amazing. Anyway. All right, chronic bronchitis is different. You don't have destruction of the alveoli. You have chronic inflammation of the bronchus. So it's the road leading to the lung. So there's mucus and plugging and spasm and irritation. Cigarette smoking is once again the problem, but this is not a problem with diffusion like emphysema is. This is a problem with the highway. the road to the alveoli. Chronic mucus production, plugging of the airways. So it is a problem with the alveoli in that there's mucus in there, but the structure of the alveoli is preserved. Okay, lower ventilation, hypoxia, hypercarbia. These people retain CO2 more than emphysema patients do, and so that's why they're blue, because they're blue bloated. They're usually heavier, and they're blue. Cigarette smoking is the most common. Frequent respiratory infections, but chronic bronchitis, that's what you would expect from someone with chronic bronchitis. They always have bronchitis. But they have it, productive cough 3 months per year for 2 or more years. They have rhonchi, which is occlusion of the larger airways, basically wheezing. May have right heart failure just like the emphysema patients because they can get pulmonary hypertension, supplemental oxygen airway, pulse ox, bronchodilators, get their SAT up in the 90-95 range. CPAP, if it's severe, you may have to assist them with a bag belt mask, intubation or CPAP. Once again, INT, bronchodilators, use a lot of steroids. IV steroids and nebulized breathing treatments. Asthma is chronic inflammation of the airways, but it's more reversible with acute obstructions induced by triggers. Environmental allergens are most common, yes.
Is the treatment for chronic bronchitis, it seems in my mind like a daily antihistamine would be part of the regimen?
Yeah, antihistamines are a paradox, that while intuitively it may seem that they would help, the problem with antihistamines is they tend to dry secretions, which makes the mucus thicker and harder to cough up. So we don't usually treat with daily antihistamines for COPD, but that's a good question. Now, antihistamines may be helpful on a daily basis with asthmatics. If they have seasonal allergies, you can fight off some of those with antihistamines. I ended up getting desensitization shots for a couple of years of my childhood, which was delightful, but it worked.
So with chronic bronchitis, it's typically caused by cigarette smoking. The cilia is just gone, right? Pretty much damaged.
Pretty much.
So what is the treatment to get that out? How do you get that out?
Well, you stop smoking, first of all. I mean, the body coughs up most of what it produces given enough time, and if you stop poisoning it, so
you
respiratory.
can regain some of that functionality with the cilia.
You can, yeah. But stopping the offending agent is key, but that so rarely happens. So rarely. Okay. Triggers can be cold, exercise. There's a well-known entity called exercise-induced asthma where athletes get it. A lot of times they can pre-treat with Proventil and then run track without having an episode. Stress, medications. First phase is the reaction where the IgE has a problem where one end of it attaches to a mast cell, which is this cell which is just chock full of vasoactive baddies like histamine, and so when the immunoglobulin recognizes its trigger and it attaches to it, it causes disruption of the mast cell and the spillage of all of these poisons, including histamine that causes bronchoconstriction, flushing and rash and whatever it's going to cause. You get bronchial smooth muscle contraction, leakage of fluid, bronchial edema. The peak flow would go down. Typically, these attacks will resolve spontaneously in an hour or two, not always. When I was a kid, they didn't have inhalants, which was tough. I could still remember the medicine I had. It was called elixophalin, which is aminophylline, which didn't work very well, and when I became a doctor, I realized why. Because we used to use aminophylline as a primary treatment when I was in training. The loading dose of aminophylline is 5.5 milligrams per kilogram, followed by a drip of 0.9 per hour. Loading dose, which means the swig of aminophylline that I took in the middle of the night was like peeing in the ocean. You know, there was no loading dose. It would have worked if I'd have taken it for 5 days and brought my blood levels up, but it was totally ineffective, which met my clinical experience with it. But things are better now, and you can abort these with steroids or bronchodilators. All right, mucus plugging is the hallmark of asthma. The secretions are thick, they plug the airways, causes hypoxia, and this can be really severe. I mean, I can remember a case of a guy in the residency who we came to find out had been abusing his inhaler all night, puffing it about 1 time per hour, and he came in a rest, and we were unable to ventilate him. And we opened his chest, and his lungs were like little shrunken lungs that would not move. So asthma can be lethal at its worst. And he died. Needless to say, he died. We were unable to ventilate him no matter what we tried. So asthma is not a benign childhood disease. It can be really severe and fatal, especially if abused. I mean, if people use the bronchodilator too much, it stops working, or it can be arrhythmogenic. All right, 6 to 8 hours after the trigger, inflammation invades the mucosa, more swelling, and it gets worse, decrease in expiratory blood flow. Wheezing is the hallmark, shortness of breath, hyperinflation, tachypnea, anxiety. Once again, finding out their medicines can help you in determining what started the attack may be helpful, but in the middle of the attack is not particularly helpful unless you plan on giving them more of it, which I wouldn't recommend doing.
And guys, on the note of asthma, we were speaking about end-tidal CO2 usage earlier. Whenever we go through the end-tidal portion, we're gonna have a lecture where I teach you about all the different waveforms. And so I want you to think back to this moment, because whenever we talk about asthma, they're having, like Dr. Kempler said, they're having difficulty upon exhalation, correct? They're trying to force the air out. You'll be able to see that correlation with an end-tidal waveform, because a normal end-tidal waveform is nice, smooth, and crisp whenever they exhale. However, if a patient is having difficulty exhaling, if they're having to force it out, you see a slope, and so they'll talk about a shark fin pattern on the waveform. So I want you to remember this moment when we talk about that.
Right, the shark fin is the curved exhalation, and then the vertical part is the inhalation. So that's the shark fin, where it's curved on one side and straight on the other side. All right, if they're on steroids, they're a high-risk patient. Okay? I mean, you don't get on steroids casually, because the medications that have combined bronchodilators and steroids, when you hear the commercials, they'll say there's an increased risk of sudden death with this medicine, which would always give me cause to pause were I to be taking said medicine. But, you know, if you can't breathe, breathing is job 1, so living is job 2. I guess job 1 comes before job 2. But there is an increased risk of sudden death of people that are on the combination steroid and bronchodilator medicines. And I don't know why that is, but it is. Wheezing are very common. Now, I remember something else my residency director taught me. He used to say, all that wheezes is not asthma. And that is true, because you can have cardiac asthma. I've seen people in failure that are wheezing. I see people with pneumonia that are wheezing. Wheezing happens, but almost all of the asthmatics are going to wheeze because they have difficulty exhaling against a partially obstructed bronchus. All right, increase respiratory rate is the earliest symptom. Look at their pulse ox, just keep them over 90, they'll be fine. The peak flow is decreased, and capnography can tell you the severity, because an asthmatic that's retaining CO2 is in big trouble, because that means they're not ventilating adequately, which means they're trapping a lot of air, and that means they're becoming acidotic, arrhythmia prone, and they're failing. So they're going to need ventilatory support if you can't turn them around with medicines. All right, shark fin we talked about. Patients tend to hyperventilate, you know, because they're hypoxic, and that's going to make them ventilate faster. So our treatment is to correct the hypoxia, reverse any bronchospasm, and treat inflammatory changes. That's the steroids. We use a nebulizer. The longer the time that the symptoms have been going on, the less reversible it is, and that's because of the second phase chronic inflammatory changes that are layered on top of the primary disease. If they're running out of gas, you need to be prepared to ventilate them. Status asthmaticus is the inability to break an attack, and so if you can't ease their symptoms, it's called status, and that is also dangerous because they will fatigue and they need secondary treatment, may include intubation. All right, the patient becomes exhausted, severely acidotic, and respiratory arrest is imminent. Prepare for intubation and transport. Specific diseases in kids, a lot of kids get RSV and croup. And it is rare to have to intubate a child, but it happens. But most of these kids respond pretty well to bronchodilators. We use racemic epi in the ER all the time. And if you don't have that, I guess you could use non-racemic epi, or you could try a Proventil, although the Proventil might not have as much effect on the larynx itself as it does the bronchi underneath. The reason that croup is so bad in kids is the diameter of their airway is so small. And so if you as an adult have a 50% reduction of your airway, you still got a pretty good airway. But if you've got a 3 millimeter airway and you take it down to a 1.5 millimeter airway, you've got a problem. So beware. Steroids can be life-saving. I've got 8 grandkids, and all my mothers have Prelone at home, because you don't need to go to the emergency room or call a paramedic if your kid has croup for the 5th time. You just give them a dose of steroids and watch it melt away, and then it's fine. All right, a URI can make any pulmonary disease worse, and so a COPD patient with pneumonia is a disaster that is in the making, because they don't have the pulmonary reserve that a healthy person would have. They can't tolerate much less oxygenation than they're already getting by on, and so that is a danger. Good hand washing, covering mouth during coughs and sneezes. Viruses cause the majority of URIs. Strep accounts for 30%. URIs are self-limiting, and you know the symptoms: fevers, chills, myalgias, fevers. Diagnosed by history and physical, no intervention. Kids in epiglottitis I've talked about. You don't want to manipulate the airway. You don't even want to look at the airway. If you, and typically the patient with croup will have a history of a fever. They'll be sitting bolt upright, protecting their airway, and what is described as a cherry red epiglottis, which you don't want to see. Okay. I've seen one by mistake as I slid the endotracheal tube in, but I would never do that knowingly. You know, where you suspected epiglottitis, you don't want to touch it. You just want to transport it. All right, acetaminophen for ibuprofen for fever, saltwater gargles, blah, blah. Finish your antibiotics. Not finishing antibiotics is a leading cause of antibiotic resistance, as is all of the antibiotics that's in your food supply. So buy organic, if you can afford it. All right, pneumonia is an infection of the lungs. Common medical problem, especially in the aged. It's known as the nursing home's friend, because it's the end of so many nursing home patients. Those infected with HIV, it's a leading cause of death in the elderly and the HIV patients, and the 5th overall leading cause of death in the United States. Risk factor, alcoholics tend to get aspiration pneumonia from failure to protect their airway and sleeping out in the cold and things like that. Cigarettes, smoking, cold temperature exposures, the germs invade the lungs, cause a defect in mucus production, ciliary reaction, or both. And bacterial, viral, and occasionally fungal pneumonias exist. This talks about the different types. Bronchopneumonia is diffuse and it affects parts of different alveolar groups. Lobar pneumonia affects all of the alveoli within a lobe. You know, there are 5 lobes of the lung, 3 on the right, 2 on the left. And interstitial affects all diffuse and bilateral. The bronchopneumonia is localized. The interstitial is both sides.
What is pneumococcal?
Pneumococcus is usually lobar, and pneumococcus is one of the most common and the most lethal. Pneumococcus is really a strep. It is a diplococcus, and it is the pneumonia that the pneumonia vaccines were invented to preserve. Both the Prevnar and the Pneumovax vaccinate against different strains of pneumococcal pneumonia. The hallmark of pneumococcal pneumonia is sudden onset of fever with a shaking chill, and the patient can usually tell you exactly what time the disease started. I mean, it is 3 o'clock this morning, I woke up with a shaking chill, coughing up rusty sputum with a high fever. That's pneumococcus, and it's a lobar pneumonia. Good question. All right, infection may involve the entire lung. Fluid and inflammatory cells collect in the alveoli. The alveoli may collapse, and it causes a ventilation problem. You can't get air to this consolidated lung tissue that's full of inflammatory fluid. Patients look ill, weakness, malaise, productive cough, bloody cough, pleuritic chest pain. Okay, fever, tachypnea, tachycardia, respiratory distress, RALS, x-ray findings, treated with antibiotics and supplemental oxygen to prevent hypoxia. You may need an endotracheal tube. They are going to need an IV for antibiotics and fluid support. You don't want to overhydrate them, because once again, they can drown in their own secretions if you increase their their fluid volume to the point that they're in failure, then you're gonna be adding pulmonary edema on top of pneumonia, and that's not good. Antipyretics for the fever, high mortality. All right, SARS is a viral illness first reported in China in November of 2002 from a coronavirus. Really, the only reason you need to know about this is to protect yourself, because you can't do anything for a virus in the field except for give them oxygen, make sure they're ventilating, and try like the dickens not to get it yourself, because it's contagious and you don't want it, you know. So you're going to use protective airways, protective equipment on every call. Sure you are, like I did in the ER. It's a miracle that I'm alive, because I look so many ugly diseases in the face without protective gear that I can't even tell you. But if you have a history of someone that has traveled out of the country and they have a respiratory illness, then you need to think about this, and you need to think about the next one. That's a lung cancer. Off on the left side there, that peripheral, you see, everybody see where that is? All right. So people with underlying respiratory distress are at increased risk. If you already have lung disease, having another lung disease on top of it is a problem, even if it's a viral infection. Leads to respiratory failure, may need ventilatory assistance. If you suspect SARS from out of country travel, protect yourself and notify the hospital that you're coming to so that they can take steps to isolate this patient from the rest of the universe. MERS is another similar disease from Middle East, not from China. Fever, shortness of breath. 3 to 4 out of every 10 patients that get it die, which is significant. And close contact passage, people with coexisting diseases can end up with end organ failure. Similar isolation from SARS. Lung cancer, once again, cigarette smoking is the leading cause. 20% only the lungs, 35% spread lymphatically, and 45% have distant metastases. There are some exciting drugs on the forefront for lung cancer. There's a certain class of drugs that have targeted this disease more effectively than the old chemo would. Chemo, the theory behind chemo is you give the body a poison, and the most metabolically active cells get the most of it, and it kills them. Unfortunately, everything slightly less metabolically active gets a piece of the action too. So your hair falls out and your mucous membranes erode and all of the rapidly reproducing tissues in your body get hit. Some of these new drugs are more effective and more target specific, and more recently I've read about them taking T cells out of the patient, changing the receptors on the T cell to recognize the cancer, and then infusing them back into the patient so that the patient's own body cells can now recognize the cancer and attack and destroy it.
Now, is that isolated to lung cancer?
No, that's a lot of cancers. So that is going to be, and I've read about stem cells being used also. So there are many different fronts that that have potential for beating a disease that we've been looking for the silver bullet for many years. And for example, Jimmy Carter had a metastatic melanoma to his brain. And when I heard that, I said, 6 months, he's gone. And they ended up taking some of his cells and altering them, and he beat melanoma metastatic to the brain. His own cells destroyed the tumor, which was unheard of not that many years ago. So there are some exciting things going on with getting the patient's own body to selectively attack the altered cells. And you understand what cancer is. Cancer is a genetically mutated cell that has lost the capacity to regulate its own growth. So whether it's UV radiation or too much X-rays or the sun or the pesticide that you used indiscriminately or cigarette smoking or whatever, something has caused this cell to be genetically altered, and it's lost control of its ability to regulate its own growth, and it ends up reproducing wildly, and it crowds things out of the way. And if it's the wrong kind of cell, it has pieces of it break off and metastasize to other places, and it can kill you by robbing your body of all of the nutrients if the tumor load gets so high, or it can crowd relatively important structures like your brain, or your lungs, or your circulatory system, or whatever, and it just crowd out your bone marrow. If it's leukemia, you find that your blood forming cells have been replaced by non-blood forming tumor cells, and you die of aplastic anemia or infection or bleeding or something. So it's a bad disease, and there's some real positive things on the horizon that might end up finally getting some control of this. Risk factors: cigarette smoking is number one. Asbestos causes a disease called mesothelioma. You've probably heard the attorneys talking about it on the TV. Asbestos used to be big in insulating materials and ceiling tiles. When I was in school, we targeted shipbuilders. They had a high exposure to asbestos for some reason. And it causes a specific disease called mesothelioma, which is a lung tumor that is debilitating. Radon from your home, fumes from metal production, but the vast majority is cigarette smoke induced. Adenocarcinoma: adeno means the gland, so that's the glandular tissue in the lung. Small cell is oat cell, that's bronchial tissue. Epidermoid are bronchial tissue, and large cell are also bronchial tissue. Most patients die within a year of the diagnosis. You address respiratory distress. Uncontrollable hemoptysis is not uncommon. These things erode through arterioles. You know how vascular the lung is. So if they erode through an arteriole, then I've seen patients rapidly exsanguinate and asphyxiate from eroding the wrong blood vessel in their chest. And it's dramatic. All of a sudden you have someone who's endotracheally intubated, and they are just blowing blood out of the tube. It's dramatic and ugly, and you don't ever want to see it. Metastatic symptoms can depend on where the met has gone. So if it's gone to the brain, you could have seizures, you could have alterations in the level of consciousness. If it's gone to the bone, you can have pathogenic fractures or bone pain. Anywhere it goes can cause symptoms in that area. Weight loss due to the tumor load. you can have rowels, bronchi, wheezes, diminished breath sounds. Supplemental oxygen, beware of DNR orders. Local protocol is that we honor them if we deem them to be valid. But you gotta be careful with DNRs. You gotta make sure that it's valid, and I always was in the habit of treating first and getting to the bottom of the DNR second. You know, you don't ever want to get into a situation where you fail to treat someone that should have been treated. I'd much rather explain to the family how I treated someone that they didn't want treated than that I allowed their loved one to die when that wasn't on their agenda. So if you have to make a mistake, you treat. And ask questions later. But I'd ask the questions early, but if there's any doubt that you have a valid DNR, you treat first. And I've apologized to a lot of people for coding their loved ones when eventually a DNR showed up. And I'd explain to them time and time again that the paramedic in the field had no choice but to treat in the presumption of life. So, all right, INT if necessary, local protocol, toxic inhalation, destruction of pulmonary tissues, fires, toxic products of combustion, steam inhalation. Any of these things can cause an airway damage, disrupts the membranes, tracheal edema. Several things can cause problems: ammonia, nitrogen oxide that causes nitric acid, sulfur dioxide causes sulfurous acid, sulfur trioxide, sulfuric acid, chlorine causes hydrochloric acid. And all these things are very irritable. If you find yourself in the presence of these, you are going to know it. You know, carbon monoxide, you're not going to know. It's odorless and tasteless, but no one gets around chlorine and doesn't know they're around chlorine. It is obnoxious. All right, duration of exposure, pay attention to the perioral areas, particular matter, wheezing, crackles, pulmonary edema. Open the airway, humidified oxygen. Once again, these people may need early intubation, so if things are getting worse, you want to provide a definitive airway pretty quickly. Carbon monoxide, incomplete burning of fossil fuels. Every year we see several of these. People, I've seen it from faulty propane heaters indoors to people charcoal grilling indoors, to having a fire indoors. Anything, running a generator in the basement that is not vented to the outside, all kinds of stupidity. And the products of combustion are odorless and tasteless and lethal. If you get your carboxy level up to 30 or 40%, you're in a coma. You probably have irreversible brain disease, and it's bad. And we've seen whole families wiped out from this. They just go to sleep and never wake up. We talked about how it has the affinity for hemoglobin. It displaces oxygen, so you have hypoxia at the tissue level, and 100% oxygen is the best you can do. Make sure they're ventilating, obviously, but you can decrease the half-life to 40 minutes with 100% oxygen. The half-life is normally about 2 hours, as I understand, from room air. So you give these people 100% oxygen and let them stay on it. And the other treatment is a hyperbaric chamber if one is available. I think there's some in Atlanta. Back when I started, we used to have to send them up to Duke, where they had the dive chambers, but now they're more plentiful.
Dr. Kempler, what are the primary differences between the ones located in Atlanta and the one located at Lanier Park Hospital? Why is the one at Lanier I mean, I know we transport patients there, non-emergency for wound care therapy. Is it the same device? Are there different capabilities?
I don't know that, but I would think that the more atmospheres you could dive someone to, the better it would be. You know, so it may be that the one at Lanier Park only goes up to 2 or 3 atmospheres and that the other ones are higher power than that. But I don't know the answer to that. Okay, we talked about that, talked about that. All right, the length and location is important. You know, I'm gonna get a blood gas and that's gonna tell me the percent of carboxyhemoglobin. And if it's 10 or less, 100% oxygen for a couple hours and they're good to go. 20 is getting to the point that you'd have confusion. 30 and 40 are at the point that you're probably gonna want a hyperbaric chamber because it is well reported that people have learning deficits that do not get better after they've had levels of carbon monoxide poisoning to this level. The skin is described as bright cherry red. Can't say that I've ever seen that, although it's always bantered about. The signs: headache, nausea, loss of consciousness, loss of coordination. Right, signs of hypoxia. You don't usually see cyanosis because carboxyhemoglobin is supposed to be cherry red, so it's not blue like deoxygenated hemoglobin is. So you wouldn't expect cyanosis really. We do carbon monoxide measuring with the blood gas. Make sure you don't get exposed. Make sure the airway is open. Remove them from the site of exposure. And 100% oxygen is what's important. Usually, except for fatal cases, these people are breathing. They're hyperventilating because they have hypoxia at the tissue level, and their respiratory drive is on high because they're hypoxic. So you usually don't have to assist these patients. So a non-rebreather, tight fitting non-rebreather. Assist respirations if necessary, treat shock. Hyperbaric we talked about. That's unclear. Pretty clear from my understanding is if you have high levels, the hyperbaric will not only clear it, but alleviate some of the neurologic sequelae, allegedly. Pulmonary embolus is a blood clot that lodges in the pulmonary artery, blocking blood flow through the vessel. If this is large, it can affect enough of the circulation to cause someone to go into arrest. In fact, pulmonary embolus is, I believe, the 5th most common cause of sudden death among patients. If it doesn't kill you immediately, it can cause respiratory distress because it alters the blood flow through the lungs, so you have a part of the lung that's being ventilated that's not being perfused. So there's no oxygen exchange, so it's not happening. Because I told you, it takes all 3 legs of this thing for it to walk. All right, so 1 in 5 cases of sudden death, pulmonary embolus, anything that immobilizes the extremity. So typically, people describe having a pulmonary embolus after a long car ride or a plane ride where they're sitting in one place for a long period of time. They get out, knock it loose, hits the lungs, and they have a syncopal episode or have sudden onset of pleuritic chest pain or shortness of breath or both.
What chest pain?
Pleuritic chest pain, where the pain is worse when you breathe.
Oh.
So if the embolus, I've seen emboli where it looks like a triangle radiating out from the occluded artery on the chest x-ray when it shows up, doesn't always show up. But sometimes the base of the triangle is abutting the pleura, the linings of the lung. And if that happens, there's inflammation of the pleura, and you may have a friction rub, and you have pain every time you take a deep breath. That rubs, the pleura rubs together. So pleuritic chest pain means hurts when you breathe. and that's a sign of inflammation of the pleura. Okay?
Would that also be what's classified as anterior chest pain?
Anterior means in the front. So you could have pleuritic chest pain that's posterior or anterior or lateral or anything. Anterior is a direction. Pleuritic means it comes from irritation of the pleura, so it's worse with breathing because that's when the two surfaces rub against each other. Good questions. All right. So here's some of the risk factors. Atrial fib is a common cause of clot because of decreased circulation. Cancer causes hypercoagulability, where the blood coagulates due to the tumor factors. Pregnancy, sickle cell. The source can be a lot of things. Fat embolism most commonly comes from a hip fracture. There's fat inside the femur, and when you fracture and you liberate that fat, it comes up the venous circulation, lodges in the pulmonary capillaries, and causes a fat embolus. Amniotic fluid embolism is obviously happens around the time of delivery, where there's release of amniotic fluid into the circulation, and it embolizes and lodges in the pulmonary circulation. So the problem is a perfusion disorder, so you can't get blood to the lung so that it can oxygenate it. So it causes it's called a VQ mismatch, ventilation perfusion. Q stands for perfusion. So when we're checking for this, there are two ways that we diagnose it in the ER. One is we do a VQ scan, which is a ventilation perfusion scan, and what they do is they inject a radionuclide into the blood, and they get the patient to inhale a radionuclide, a different one, and then they scan them, and they can see what segments of the lung are ventilated, and they can see what segments of the lung are perfused. And if they find a section that's ventilated, but it's not perfused, it's a blood clot, okay? If they find a segment that's not ventilated and not perfused, that's COPD, because the body is smart and it recognizes when there are useless areas of the lung to perfuse, and it shunts the blood away from an ineffective area, so it'll compensate for COPD as much as it can by shunting blood to the ventilated sections and away from the unventilated. So that's called a VQ match. That's COPD. And they're looking for a VQ mismatch to diagnose a pulmonary embolus. The other way, which is more modern, is called a CT angiogram, where they inject some dye and do a CT of the chest, and they can visualize the pulmonary arteries and capillaries, and they can see if there's a cutoff from the clot, and they can see where the clot is and how big the clot and all that kind of business. So those are the two ways we diagnose that. We also screen for it, if you're interested, using a test called a D-dimer. And a D-dimer, you have no reason to know this, but I'm just throwing stuff out as we go, so you have breadth of knowledge. A D-dimer is a degradation product of thrombin, which is a blood clot. So what your body does is when you, and your body is clotting and unclotting all of the time. So you have a normal baseline D-dimer level, which reflects the normal clotting and breakdown of clot in your body. But in a pulmonary embolus, there is excessive clot. So there's excessive clot breakdown, so there's an elevated D-dimer. So there's a blood test that we can do in the ER to measure how much blood clot is being broken down. And if it's elevated, then we proceed to the D-dimer, to the VQ scan or the CT angiogram. So we use that as a screening test for pulmonary embolus. Okay, so sudden severe unexplained dyspnea, history of immobilization, labor, breathing, tachycardia, tachypnea, right heart failure, because if this is big, it causes acute right-sided heart failure. The diagnosis of heart failure is the inability of the heart to pump that which is delivered to it. Okay, so right heart failure means the right ventricle can't handle whatever venous return is coming back. And left heart failure means the left ventricle can't handle whatever blood is returning to it. Okay, so if there's a blockage in the pulmonary artery, then the back pressure increases and it's transmitted back to the right heart. The right heart may fail if the clot is large enough. All right, you may find a thick cord, you may not. Petechiae on the arms and chest wall, can't say I ever saw that. First priorities are ABCs. You may have a cardiac arrest. If you have a cardiac arrest due to a massive pulmonary embolus, chances are they're not going to respond to your resuscitation. Okay, you may get lucky and break it up doing CPR and it'll go distally. That would be the best case scenario, but this is a bad disease and you got a big blockage in the way. Now, some of the ones that don't suddenly arrest, couple entities, they now use TPA to break it down, which can be effective if it's not a lethal one. They can do thrombectomies where they go in and pluck the clot out of there, but you got to have a specialized center and an operator that is expert at going in and doing it with a catheter.
So PE is like a systemic infarct.
PE is a pulmonary infarct.
But it would,
Pulmonary embolus.
but that's the main issue, right?
The issue is that there's a large blockage in the circulation to the lungs. Okay, so yes, you can get an infarct. You don't always get an infarct from a pulmonary embolus because the collateral blood supply of the lung is good. But the problem is a failure of perfusion of a large part of the lung so that you can't oxygenate, and if it's big enough, then you have a critical failure of venous return to the left side because it can't get through the lungs because of the blockage, so you end up with hypotension, shock, and arrest. You know, you arrest because your blood pressure falls or your oxygen level falls. If your blood pressure falls, you don't perfuse your coronary arteries and you have a heart attack and die. If you can't oxygenate,
Is a PE just in the lung, or could it be in the pulmonary artery or vein? Could it be in either one of those is still classified as a PE?
No.
Okay.
That's a good question though. Okay, a pulmonary embolus is a clot that is stuck in the lungs. If you have a clot in the pulmonary artery, it's going out the aorta and it's going to your brain and causing a stroke, or to your toes and causing your toes to fall off, or to your kidney and causing you to have a renal infarct, or your heart and cause you to have a heart attack. You know, if it's on the left side of the heart, if it's anywhere from the pulmonary vein, which is leaving the lungs, to the left atrium, to the left ventricle, or out, it's systemic. Okay, so pulmonary embolus is a right-sided event. But there are arterial emboli. I mean, like people that have, well, there's an exception to that. Some people have what's called a patent foramen ovale, which is an embryonic structure that connects a little hole between the right atrium and the left atrium. The purpose of this is when you're in utero, you're not using your lungs. So blood is coming up your umbilical artery into your vena cava, and it comes into your right atrium, and it's not going to go out your right ventricle because your lungs are not ventilating. There's no reason for it. So it crosses through this embryologic hole in your atrium to your left atrium and goes out the left side because it's already oxygenated. You got oxygenated from your umbilicus, you know, from the placenta. When you're born, the flaps mostly come together, usually come together and occlude the foramen ovale. In some patients, there's an entity called a persistent foramen ovale, where the hole stays open. So it is possible for a right-sided clot from a leg embolus to get across to the systemic circulation. Rare, but possible. But I don't want to tell you something can't happen if it can happen. But you'll probably never see that, but it is possible for a right-sided embolus to get systemic. But usually a left-sided embolus, like if you have a left atrial clot, you know, people in atrial fib tend to get clots in their left atrial appendage. And so that's why all of the ads you see on the TV for the new Eliquis and all these things say if you have atrial fibrillation not related to a valve disorder, that's atrial fib with a potential clot in the left atrial appendage. So your risk of having a stroke or a systemic infarct is really increased because your clot's coming out of your left side and your left atrium. Incidentally, they've come up with some new procedures for that, if you're interested. They now have a catheter-delivered pillow that they put into the left atrial appendage, and because the left atrial appendage is like a pig's ear sitting on the left atrium, and it's dead space. And so the blood pools in there, so that's where 95% of the clots in atrial fib come from. And so they found that if they inflate this little device and obliterate that space, people in atrial fib can come off of their anticoagulants with minimal risk. I would not like to be on anticoagulants. I would worry about getting a head conk and them not being able to operate on me for 4 days or whatever. Anticoagulants are not without risk. And so this is a pretty cool procedure where they can obliterate that space. All right, but once again, we diverge. So we've talked about all this, right? All right. We're talking about, oh yeah, pulmonary embolus. Okay. So you may need to assess ventilations. Once again, these people are usually breathing like crazy because they're hypoxic and the drive is intact. If they're not breathing, it's usually because they're about to arrest or they've already arrested because they've lost the will to breathe. Transport quickly, or spontaneous pneumo. You can get this with no trauma. I've seen it in lots of patients. Typically, late age teenagers, early 20s, sudden onset of shortness of breath. If you listen to the breath sounds, you will hear diminished breath sounds on the affected side. The chest X-ray is diagnostic. You can see this in asthmatics. They typically have spontaneous pneumomediastinums. Rarely they can collapse a lung, which is like insult to injury. If you're already having trouble breathing and you lose a lung, you've lost one cylinder and you only have two. That can put you over the edge. You don't want to miss this, because if you're in a situation where you're about to provide positive pressure ventilation, the incidence of pneumothorax goes up with positive pressure ventilation, as does the incidence of tension pneumothorax, which is even more critical. How does a tension pneumothorax kill you? Pressure on the heart? Not exactly. Huh? So what happens if you increase the intrathoracic? Right, yeah. So I told you that breathing is a negative intrathoracic event, negative pressure intrathoracic event. So venous return is dependent on negative intrathoracic pressure, which you generate when you expand your chest wall and drop your diaphragms. But if you have a tension pneumo, you have positive pressure in your chest, so you have a paralysis of venous return, if the heart doesn't get blood, it can't pump blood. And so your blood pressure drops and you die because your heart is not getting any volume to pump. And the higher the pressure, the less the venous return. So your treatment is to restore negative pressure to the chest. You can't fix a tension pneumo by breathing them. You can't do positive pressure and affect the venous return. You could force air into their lungs, you would be increasing the tension pneumo in all likelihood if you did it. But the key is restoring negative intrathoracic pressure, and you have to do that with a needle. And that is dramatic and gratifying when it happens. That
So
whistle
for-
device.
So
Huh?
for venous return, we depend on skeletal muscles up till the point, well, movement and skeletal muscles up to the point that we get to the diaphragm, when all that goes away. So, you're saying between the diaphragm and the inferior vena cava or the superior vena cava, it's the negative and positive pressures that continue to push blood up to the heart, or
pull blood up
to the heart, rather?
yes.
Okay.
Where somewhere Sandstone just twitched and said, "Box of life? Box of life?"
He twitches a lot, doesn't he? Okay. 5-to-1 male to female. I don't know why that is, but it's true. Most of the ones I've treated are young males. Risk factors: tall, thin, cigarette smoking, high incidence with COPD. I've seen a lot of lungers that get acutely worse that pop the pneumo. They pop a bleb. They don't always need chest tubes. They rarely need a needle, but 10-20% pneumos where a bleb pops, not uncommon. All right, this is a problem with ventilation. Negative pressure in the pleural space is lost, prevents the proper expansion of the lung. Sudden onset of sharp pleuritic, worse with breathing, chest pain, shoulder pain, dyspnea, common, rapid heartbeat, diaphoresis. Give them oxygen, measure their SAT. If they require positive pressure ventilation, then do that. Once again, that's unusual for a simple pneumo to require positive pressure ventilation, and increases the risk of attention. But there's an increased risk of a pneumo and tension anytime you're providing positive pressure ventilation to a patient. So just be aware of that. And I can't tell you how many times a patient gets worse. When you're treating a patient and they suddenly take a turn for the worse, the best advice I can give you is start over from your assessment. Reassess them like you never assessed them the first time, because one of the biggest mistakes that I see are relying on your first assessment and not checking to see what's changed. Something's changed. They've gotten worse. You need to look again. And that's typically a misplaced or displaced endotracheal tube, or a tension pneumo, or something has changed. The airway has become dislodged. Something's changed. You got to find it. All right. Hyperventilation. Be careful about this one. Use your SAT to guide you. As I said earlier, people don't hyperventilate themselves to an oxygen saturation of 85%. If you're normal or neurotic and you're breathing too fast because of your nerves, your SAT is going to be normal to elevated. If your SAT is low, the hyperventilation is compensatory and secondary to something bad going on. So don't bring them into my ER with a brown bag on them and a SAT of 80. We're gonna have a chat. You don't wanna have a chat. All right, carpopedal spasm. People get this kind of business when they get so alkalotic. I don't know why that is, but they do. And it goes away when they stop hyperventilating. I have never seen hyperventilation precipitate a seizure, but it says so here, so, okay. Primary treatment, reassuring. I can still remember my physical diagnosis class in medical school, where there was a young male that came in with, unbeknownst to me, was classical hyperventilation symptoms. And my instructor said, let me show you how this goes. And he took this guy and he had him inhale when he raised his hand and exhale when he lowered his hand. And the guy's chief complaints were numbness and drawing of his hands and abdominal cramps, I think. And so he hyperventilated this guy for about 30 seconds. And after 30 seconds, the patient's face turned red and he got the abdominal cramps and he said, that's exactly what I've been feeling. And so he de-escalated him, and we had both learned a lesson that, you know, hyperventilation can cause all kinds of squirrely things, but it is easily reproducible if you know what it is and how to provoke it. Not that you want to be provoking people in the field, but once again, use your knowledge and use your SAT to help guide you. And if you need to reassure someone, you can reassure them. Try and get them to slow down their breathing. Once again, beware of secondary things. Pulmonary embolus and MI can cause hyperventilation due to hypoxia, and use your pulse ox to sort that out. CNS dysfunction, strokes, anything that affects the medulla can affect the respiratory centers. So if your brain's not telling your body to breathe right, it's not going to breathe right. So just be aware that tumors, drugs, head trauma, strokes can do that. The treatment is the same. You just assess the airway, make sure it's open, make sure they're breathing, make sure they're saturating, provide them enough oxygen to saturate them, step in with assisting their ventilation if that's the recurrent theme in all of these things. Just assess them and make sure they're getting enough, an open airway, enough oxygen, and enough ventilation. We'll talk about that. All right. Spinal cord or respiratory muscles, things like ALS, myasthenia gravis, anything that affects your muscles affects your ability to generate negative intrathoracic pressure. And so if you can't generate negative intrathoracic pressure, you can't breathe, and you can't venous return, and you can't live for long without help. So you're the help. Right? They're at risk for developing pneumonia because they don't clear their secretions effectively. If you can't use your muscles, you can't cough. You can't clear things, and it stays down there, and it gets infected, and you end up sicker. Always beware of the cervical spine. Anytime there's trauma, you can intubate someone, but you need to have someone maintaining control of the cervical spine, and don't hyperextend the spine. You know, I've intubated many a traumatic patient with someone else hanging onto their ears. I try and do it with the collar in place. Sometimes you can't do it with the collar in place, you know, but you just have to have inline stabilization, maybe with a little bit of traction, and then you do what you got to do.
When you say traction, are you talking about the jaw, or what
No, I mean inline, straight inline. You know, just like the neurosurgeon, if he comes in and puts a halo on someone, there's a ring and screws, and there's traction in that direction.
Oh, okay, gotcha.
You know, so you're elongating the spine. The thing that kills you with spine trauma is flexion, where you end up pithing the spinal cord between the bones. As you know, the canal's like this, and if you do this, all of a sudden there's a right turn in the bony canal. So you want it elongated, you want traction in the direction of the spinal cord so that there's no flexion or extension that goes on.
So if we're putting a C-collar on somebody, this may be outside of our scope, since we can't really look at the spine, but if we suspect a spinal injury, should we provide traction as
Yeah.
we put the collar on, not just sliding it underneath them, but provide traction and try to pull back?
That's the
and fit it
safest.
as tight as we can underneath.
That's the safest, to have inline traction. And that's what the neurosurgeon's gonna do when he sees the x-ray. You know, you wanna avoid flexion or extension. Flexion is usually the worst. But either one, I mean, anything that causes, I mean, you think about it, you got this thing going through a bony canal, and now you've broken that canal. You don't want anything that causes narrowing of that canal. And so the way that that's protected is by elongating it. So you're pulling it in line and maintaining the alignment of it. So ideally, if you're putting a C-collar on, I'd have one guy holding the ears and putting gentle traction. You know, you don't want to distract things, but gentle traction while the other person is sliding the collar on.
Something that needs to be in the National Registry curriculum. We can add that and take out percussion.
I'll leave that up to you.
Is that more what the C-collar is designed to do, is to provide that gentle traction, or is it really just to limit the range of motion?
I think it's the limit flexion, extension.
I don't know if it's just one of those things that got lost in translation over the years.
No, you know, I think that, you know, having a one-size-fits-all is tough. Excuse me. You know, to effectively provide traction, you'd have to have a custom-fitted collar, because everybody's distance is different, you know, and how would you know what size collar to put on if you know, it would be hard to do that with a standard collar. As I say, the neurosurgeon, what they do is they put a halo on with four bolts, and that goes to a pulley, and that goes to weights, you know, like 10 pounds of weight. And, you know, and that provides inline traction all the time until they surgically fix it. Okay, questions? Is that it? Okay. Yes.
Got one quick question.
Sure.
Back to pneumonia. I've heard if you misdiagnose CHF and treat